What happens if we flip the traditional way of sharing medical information to the wider population on its head? What happens if instead of letting algorithms or the zeitgeist of the moment order our social media feeds, we go straight to the source of clinical medicine and ask practicing experts what they see day in, day out, and give them an unedited platform to help disseminate practical medical information straight from the specialist?
I was thinking about yesterday in this meeting. Generally, there are so many people going above and beyond and doing all sorts of things for their patient that often their patient has no idea about.
And I think it's really easy for patients to understand what they see. I think what we see, we understand.
Mm-hmm.
So you see these nurses getting you an extra pillow, you know, those caring acts.
Mm-hmm.
But if you don't see the machinery behind the scenes,
you don't see your doctor advocating for you with other specialists. You don't see your doctor calling in colleagues to get the best result, or negotiating with managers, or all of that is invisible.
Yeah, for sure. I've called in so many favours. Well, favours in a way that in the business world, it's quid pro quo, but in medicine, we do it just because it's our patient. It was fun. It was fun working in the hospitals.
Mm-hmm.
In the NHS.
I think there's a similar thing in private healthcare.
True.
In that what you need, what your patient needs, isn't necessarily easily available.
Mm-mm. There are less streamlined pathways, for sure.
Mm-hmm.
And so you need to make sure that you're navigating them properly.
Yeah.
Yeah, for sure. And my patients are much younger, so they just need a little bit of guidance, but they're pretty resourceful.
Mm-hmm.
But I'm sure, the patients you see, you see a more varied range of patients.
Yeah, I think there are some areas where private healthcare, there's some work to be done. In the UK generally, depending a little bit on whereabouts you are in the country, but there are some conditions where if you present to private healthcare, the solution isn't obvious, or you may be turned away. And the expertise may exist, it's just connecting that it requires some work.
That's an interesting point. So you're saying that, of course the expertise exists, but it's the pathways are less trodden, whereas in the NHS, there's a referral pathway and a hotline and then now,
for example, trauma patients until relatively recently, I can think of a private hospital where the approach was to fit them in at the end of a list, which is what we did 40 years ago in the NHS. And there is so much expertise to treat them appropriately. So those pathways are being written and in many cases already exist.
Mm-hmm. And they match the NHS?
No, because the makeup of patients' needs is not the same.
Mm-hmm.
And the resources are not the same. So no, there's a need for pathways that are fit for purpose.
I want to push you more on that, but I won't.
That's for another time. We have to talk about hip arthritis.
Exactly. If you listen to the Radio 4 listening project, that's sort of the tone, the conversational tone.
Yes.
That I would like.
Yeah.
And I've been working with editors, and some of them are very good and they cut out all the spaces and the ums and the ahs, but it feels less natural. So I've asked them, forget it, let's lighten your workload, let's keep it all in.
Okay.
Because I love the conversation aspect.
Yeah.
And the way I described it to another surgeon was that I think often it must access the brain in a different way.
When people are listening, is that what you mean?
Yeah. As when something's structured and when there's information dense and you're in a lecture, at least for me, maybe my brain starts secreting or my body starts secreting cortisol and it shuts down a few parts of my brain.
Yeah.
Whereas if it's in a conversation, you can take more on board. And I suspect that's what happens when patients come into our consultations. They don't remember a thing. And I'd like to think that I explain things in a simple enough manner for them to understand, but I think it is just the cortisol secretion, and not being in a familiar environment. So that's also what I want to capture.
I thought I'd explain 2 very straightforward things to a patient yesterday. And I just thought, at the end I said, should I write that down? Knowing that the letter in the NHS is going to take 2 weeks to get there.
Yeah, and often a letter doesn't capture what you've said sorry.
And she said, yes, please. So I just wrote down these 2 really straightforward things for her.
Yeah. So that's also what I want to do here. I don't want to just provide a lot of information because you can Google it.
Yeah.
What I want to have is a conversation.
Yes.
Happy?
I love that. I love that.
Okay.
I think you're right. The conversational setting is it taps into. I think you're right. It taps into a different part of the brain, and also where that is matched with where there's some curiosity in there from the people talking. They're curious about the subject. They're curious about each other's perspectives. I think that's a powerful engagement tool.
And I think you need to be, I'm only a sports medicine doctor. No. Let me say it because it is part of my punchline. But I've got a basic understanding of all the specialists, of what these other specialties do. So I'm more educated than, say, a journalist or somebody with natural curiosity, intellectual curiosity.
Maybe we should start recording this. It's like gold, isn't it?
Oh, I am. Don't worry.
You are recording.
I don't do this in my clinics, by the way. Usually I ask for consent, but...
I'm just thinking what happens when we have coffee together. You're probably recording all of that gossip.
No, it's only on this occasion because I know that it's this that I want to capture.
My perception of you as a sports medicine consultant is that you know a lot about the science. I think maybe a lot more than I do about that. So,
which science? The sports science or the
different aspects of science? So, biomechanical science, molecular science. I guess there may be areas. But there may be areas of interest, I suppose.
Yeah, I think the wonderful thing about medicine is that it can be condition specific. So when you first enter medical school, you're thinking, oh my God, I need to know everything about everything. But you actually realise in medicine, I need to know about the dysfunction of certain joints and tendons. So I don't need to know the foot surgeon needs to know about the intrinsic ligaments of all the midfoot of the joint. I'm sort of more interested in the textbook presentations. And then you can delve further into the tibialis posterior dysfunction. I'm less worried about things that rarely cause problems. And I think when you have those kind of spectacles on, you can do further reading. And that's what I love about medicine. So then I can know about, the basic science of tendinopathies. I can then understand about treatment more and the biomechanics, and that's how I like to structure my professional development. But I'm sure that's true of other specialists too. But it's to help demonstrate to the public that what we see and treat is textbook. It is often so easy for us to diagnose and then manage, because everything we as human beings, we tend to think we're unique and special.
We are. I think we are.
It turns out that I've had the same marital problems, not that I'm a therapist, but I've seen the same midfoot dysfunction. Yeah. It's textbook.
Yes, there are patterns that repeat. Yeah. That is part of human nature, but also that we are special.
So this is probably a good time to start. So you understand the 3 questions, and we've discussed them briefly. But actually, would you mind a quick introduction in your own words?
Yeah, sure. So I'm Homa Arshad, known as Homa Arshad at work. I have a civilian married name as well, which I won't mention here. But I was born Homa Arshad, and I've stayed Homa Arshad my whole life. And I'm a trauma and orthopaedic surgeon. I work equally in the NHS and in private practice. And I am Brinda's colleague. and very excited to talk about hip arthritis as part of my practice. My practice relates to hip and knee problems, hip and knee arthroplasty or replacement surgery, and trauma, particularly pelvic and acetabular trauma.
Okay, brilliant. And you work in London?
I work in London, yeah.
And can I just say, Thursday mornings I think will be my new favourite time, because I bump into you 10 to 9 just before we start clinic, and we have a little, I don't know, a fortnightly debrief of
I think it's in my diary now. Brynda, 8:50 at the Shard.
But it's so heartwarming for me, so thank you, because often, in private practice I feel a little isolated, so it's lovely to bump into colleagues in the corridor.
We often talk about something meaningful in a very short space of time, so
Yeah.
I think, it's good.
It is lovely. Okay, so what one thing would you like to share with the general population?
About hip arthritis,
Yeah, if that's
and I
what you chose
suppose
in your book.
looking also in the context of the bigger picture, the one thing I wish the population would think about is their choices about their health.
Mm-hmm.
And particularly when it comes to hip and possibly more about knee arthritis, we have a global pandemic of obesity. There are something like 300 million people worldwide who are morbidly obese, and the numbers are increasing. And the effect on the hip and knee is quite significant. The effect, if one needs surgery, is quite significant in terms of complications. And so in looking after your hip and in trying to prevent or mitigate the effects of hip arthritis, the choices we make about diet, lifestyle, exercise, looking after one's health, is so crucial.
Mm-hmm. So if I can talk, and you probably know far more about this than I do, but there's a soundbite that I quote in my clinics, but when people come to me with degenerative changes in their knee, so their anterior knee joint or patellofemoral joint, I say, well, 2 to 3 times your body weight in terms of forces is being transmitted to the underside of that patella, so that's the cartilage that's wearing away, every time you walk up the steps.
If you run up the stairs, that's 7 to 8 times.
I mean, it's huge.
Mm-hmm.
So for every 5 kilograms, and I've forgotten my basic science like physics, but I'm sure, it's multiples.
Mm-hmm.
And I think if you are 100 kilograms, and you're talking about obesity in terms of body mass index, so it isn't the weight per se, but it losing 10 kilograms does help.
Yes, but we've got quite robust studies now showing that carrying extra weight is very strongly linked to the development of particularly knee arthritis, and lots of other health effects. And if you already have, so you develop some sort of problem in your hip or knee, then losing some weight definitely has benefits. And so on a population level, that's hugely important. What do we do about it on an individual level? Obviously, there are a whole range of treatments, interventions, the majority of which are used in an evidence-based way. But I think there is also a bigger public health question. And we present freedom as the ability to choose, when actually so many people are trapped in poor health conditions because of the situation we find ourselves in.
And when you say poor health conditions, do you mean sort of access to nutritious food?
I mean, we can choose to smoke. We can choose to eat highly processed foods, and when we talk about research and understanding that and conveying that information, it's tied with education, but it's also tied with financial conflicts. The the detrimental health effects aren't always transparent. For example, in places where harmful foods are available, you won't find this information. And it's partly people don't want to see it. That's part of the choice around it. People want the freedom to live as they choose, but it does have consequences.
In the long run. Can you give me so the equivalent for the hip in terms of 2 to 3 times or up to 7 times your body weight in terms of forces
Well,
go
the hip,
through
the hip,
knee?
the
What is
interesting
the hip like?
Yeah, the interesting thing about the hip is we still have this hold to this theory that to develop arthritis, osteoarthritis in the hip, there must be something wrong with the shape of the hip.
Mm-hmm.
So we know that dysplasia, cam deformities predispose to arthritis in the hip, and there's also a strong genetic component in that, as you know, it's not directly inherited from a parent, but the combination of genes we're born with predisposes the cartilage of the hip to being vulnerable in cases where osteoarthritis then develops. And in terms of body weight, definitely there is a similar effect. It's not as strong as with the knee because the shape of the hip is thought to have a very strong component. But there are certainly cases where it's a theory. You must have had some problem with the shape of your hip. That's why you have arthritis. We say sometimes, but we don't know.
Right.
And we do see people of all ages.
Is that sort of consensus thinking? Is when you say we
Yes.
don't know? But
Yes, exactly.
It's broadly accepted.
Exactly. It's broadly accepted. Yeah, it's broadly accepted. But I'm sure that there is, in some cases, so it's very rare to see a patient with a severely dysplastic hip where they don't have pain. But it's cause and effect because I only see patients who are having pain. I don't see adult patients presenting because I rarely see adult patients presenting because they had a history of dysplasia in childhood and they want just to check it.
Understood. So in terms of magnitude, you're talking about maybe not the genetics as in the direct genetics that you inherit, but the sort of vague picture of people in your family.
The combination,
genes that you
well,
have.
not even people in your family. It's just the combination of genes you're born with, the throat, the
Whatever's
roll
being
of the dice.
expressed at that time. Okay. And that, in terms of magnitude, signals more than your body weight, but your body weight, you're saying, is becoming increasingly...
The body weight definitely has an effect.
It's more important,
but
it's modifiable. So that's the key.
Yes, and so nationally, there isn't robust national guidance for everyone, but many departments and many regions are adopting guidance where if the body mass index is over 40 and your hip or knee are in the sort of situation where you're contemplating surgery, then the first operation you should have is a bariatric operation. And so somebody who is overweight with a body mass index of 30, there isn't very much evidence for a significant increase in risk from the surgery. There isn't very much evidence that if they achieve a normal weight, they'll avoid surgery. Whereas for someone with a body mass index of over 40, if they can achieve a normal weight through whatever means, sometimes bariatric surgery, as many as 50% of them may avoid having joint replacement surgery.
Okay, so rather annoyingly, my telephone went off, so I was half paying attention to that. Would you mind repeating that? Oh dear. Okay, so the BMI, if it's over 40...
If it's over 40, that's a very serious health condition, and it has all sorts of potential adverse effects.
Fine, so bariatric surgery, you refer first.
Yes, and then there are funding restrictions in the National Health Service and from insurance companies too, in terms of what's available to patients who are seeking weight loss intervention, and the main message is for patients who are in that category, a hip or knee replacement is a hazardous thing to have.
Okay.
Because you have a significantly higher chance of the implant loosening early and of having perioperative problems like wound infection, deep vein thrombosis, cardiac complications. And so patients sometimes say, when we didn't know as much about this 6 years ago, you did my hip replacement and it's great. Can I have the other one done now? Because it's in the same state.
Yeah.
And I say, well, each time we roll the dice, and I want to know that I've done my best for you. And so, knowing what I know now, I'm going to send you to the bariatric service, because if they can't help you and I do your hip replacement and something happens that we didn't want to happen, then at least I'll know I did my best.
Okay. Thank you for explaining that. I mean, maybe this is too complex a question, and I need to go and read some of those papers that you were talking about.
I feel like you're grilling me now, Brenda.
No, I know, but I'm so curious, and I'd rather ask the expert than go have to do the work myself.
I will answer as best I can.
It's out of laziness.
No, I don't believe that. I think
It's
you're being very
no.
modest. I think these conversations are very different from just looking at something in a dry way without this question answer. It's like a game of tennis. Much more fun.
And often professionally, sometimes you don't want to ask those questions in an MDT for looking a little foolish. But I hope one day I'm confident enough to not mind looking foolish.
But I think
because I know that I'm not.
The thing is, we're all signed up to lifelong learning. And so if people are not asking questions, simple or complicated questions, in an MDT, that's a dysfunction of the MDT.
Yeah. And just so the general population know, I need to do 50, or I need to demonstrate 50 hours of learning every year. That's on top of working and just learning within work. Is it the same for you?
Yes.
So paediatrics,
yes,
I think, need to demonstrate more, and I think different colleges for different specialties need to do more. But it's a lifelong process of learning.
Of course.
So, because I don't want to Google things, and in the spirit of this podcast, I've got the specialist in front of me. What are some of the proposed mechanisms for this increase in risk of having your higher BMI patients have increased infections?
Yes.
Loosening of the hip joint, I think I can understand sort of the biomechanical forces that we're talking about. So the capacity of that joint, it just needs to take more.
What I find really fascinating is, yes, logically, if there's more load, then you would expect there to be a point of failure. But it's more than that. There are cytokines released by fatty tissue.
Okay.
And so there are metabolic effects too. And in the development of osteoarthritis, there are theories that there's mechanical effect, of course, but also the effect of a metabolic effect on the cartilage. So it is probably multifactorial.
And I think we've overplayed, sorry to interrupt, but I think historically we may have, in trying to explain to patients, we may have...
I thought we agreed we can interrupt each other.
Okay. But remember that thought. I don't want you to lose it. We try and oversimplify things, but we actually don't do the pathology justice. So yes, I can explain the biomechanics. That's simple enough for a patient to understand. But to start talking about cytokines in my appointment, I think that's a bit too complex. So I often leave that to one side. But that's what I want
to take you back to the point I want to press about humans being special and individual. Yes, there are patterns. There are patterns of disease, there are patterns of behaviour, of course. But I had a patient the other day who said, as I turned my screen, no, don't show me the image of my knee MRI scan. I can't bear to see it. And it's so unusual because people are generally curious about their
often the other way, they're requesting their MRI so they can take home.
Well, I've started, for patients who are particularly curious, recording a short video where I point out the features, because I know that if they take a disc home, lovely. They have no idea what they're looking at.
Well, that's lovely.
And so, and everyone's different. And of course, we've all been on the receiving end as patients, and I'm so grateful for colleagues who take the time to know what matters to me, and to explain what matters to me, but at the same time not gloss over things because I'm a doctor, to treat me as a patient, but to treat me as an individual. So I try and do the same. I think
for sure. But I think it can be hard to judge. I think if you're a GP and it's a well-known patient to you, you know the family, you know what they're like, you build up a relationship. For me, the one-on-one, when it's first or second encounter, I can try and figure out who they are. You know, if there's a trader and they work in energy and oil, and I just have to make a assumption, because that's all I have, that maybe going into cytokines is a bit too much for them.
Yeah.
But that's why I want to talk about it here, is that at least now we're saying that somehow these, we now call it a metabolic condition. So it isn't just obesity. We know that the fact that you have maybe something the endocrine system's not working. You have a collection of fat cells. They may be somehow secreting or signaling inflammation, and that's what you mean by cytokines.
And inflammation is a key part of osteoarthritis.
Yeah.
And so we talk about this degenerative condition, but there is an inflammatory component to it, as you know, and huge interest also in the. Is it too early to talk about the microbiome?
No, that's how I explain it, because I think patients do know about the microbiome thanks to our colleagues.
But they know different things about it, and it comes across in different ways. Patients sometimes say, I've decided to cut out, I had a patient who said, I've decided to cut out all refined sugar from my diet.
Yeah.
And alarmingly, she said that wine is a high source of producing refined sugar in the body. I don't know if that's true or not, but anyway, that was bad news.
Fake news, you mean?
Must be. But there are these dietary ideas. If I cut out this, I might feel better.
For sure.
And I think there's a lot of.
It's oversimplified. Because the
yes.
bacteria I have in my gut is different to yours.
Yes.
So I may respond differently to you. And that's why I think those continual blood glucose monitors are useful, because they help, a bit like the Fitbits or the Oura Rings, and I'm not sponsored, but they help teach the individual about the foods that may or may not be good for them and how they respond and how they feel. Because and this is another topic, but another thing I like to teach my patients is this concept of interoception. So how you feel after a training load, how you feel after that sort of running, marathon running schedule, because different individuals respond differently to the training programs, and that's where bespoke training programs come into it, and a coach for a Premier League football team can individualize that. But for us mere mortals, when we download a running program couched to 5k, sometimes it's too much for us, sometimes it's not enough, and sometimes it's just right.
And I think that is a key concept with hip arthritis. So in the population, if I'm diagnosed with hip arthritis, or I think I have a risk of that, what can I do to protect myself? And strengthening is a really key part of that, control over the hip. But the right regime is different for every patient, and listening to your body is so key.
Yeah, and that's where perhaps I, as the sports medic and the physiotherapist, come in to help with that journey. Sorry, we've veered off.
I wanted to talk about a study, an
Yes, go
MRI
for it.
study. I don't know if you've come across this, an MRI study that was done about 5 years ago, I think.
Okay.
Looking at patients who run and what happens to their hips if they have damaged cartilage.
Okay.
They did it for knees and they did it for hips.
Okay.
And there used to be this theory, particularly surgeons used to say, you have damaged joint, don't run.
Oh yeah.
Impact is bad. And it's just
I have to
true.
unpack that in my consultation. I'm like, well, it's not quite as simple as that. And I probably will say, I won't repeat the same. Carry on.
And so we know that cartilage can remodel and strengthen, and the effect on the bone is very significant, and running is good for your body. But running where you have pain and you run through the pain, obviously that's not good.
Yeah.
Body's telling you there's pain for a reason.
Yeah. Yeah. So all tissue has a capacity. Okay. So when you train, this is audio, so you can't see my hands, but when you train and you load it just on the cusp of your capacity, the body's pretty miraculous, and the next week its capacity increases. And you train and it increases. If you load it somewhere over here and your capacity is here, that tissue will break down.
Yeah.
So this is now diseased or pathologized tissue. So then even your activities of daily living are now outside the normal capacity. So then sort of getting up, walking down the stairs, pain. But the good news is most tissue, soft tissue, does remodel or heal within 3 months. But then when we're dealing with these degenerative conditions such as hip, osteoarthritis, what are the synonyms? Osteoarthritis, degenerative hip, what are the other things you call it?
Oh, people often, patients come with their own terminology.
Oh, okay. But medically speaking, are those the two?
Yeah, osteoarthritis, arthritis, yeah.
Arthritis, okay, arthritis.
Arthritis. If someone says arthritis, a colleague says arthritis,
Yeah.
I'll expect they mean osteoarthritis.
Yeah, okay.
Because it's the commonest one.
Because there are other types of arthritis, like an inflammatory arthritis, the most
Rheumatoid
popular one being
arthritis.
rheumatoid, most notable, being rheumatoid. Okay. Okay, brilliant. Is there anything...
The effect of aging on cartilage. Because we talk about it as a degenerative condition, people often people say, "Gosh, well, as I get older, I'm inevitably going to get arthritis." Of course, we know that's not true.
Yeah.
And patients who are young who get hip arthritis are often devastated by the idea that they're old before their time. But the reality is, trying to live with advanced arthritis in your best years is often impossible, and it's not a choice many want to make, and so they shouldn't be fearful of having the treatment they need if it's a hip replacement.
True, but we often suggest different management strategies for your symptoms and not the scan findings. Is that correct?
Yes. So the scan findings are useful to determine a diagnosis or a pathology. And then the symptoms are, I would say the symptoms are more important. So
if you were to x-ray my knee, I probably wouldn't have a great patellofemoral joint. But it's not bothering me.
have you seen this?
It's not bothering me. So should I allow that worry to signal in the back of my head that, oh, I've got degenerative changes in my knee?
I love that you say worry, because that brings me on to... gosh, we could talk about this all day. But, it brings me on to...
the editor costs me money. We have to keep it snappy.
Psychology. As you know, mental health, physical health are closely entwined. Worry doesn't help. So I try and encourage patients not to worry, and to focus that, and telling people don't do this, don't is not a helpful strategy. It's more transform that worry. So you have worry, can we turn that into curiosity about what you could do to look after your knee? So what about some running? And that the conversation goes, well, I'm worried about that. And I try and explain why it could be helpful, and that maybe they are curious, maybe they want to explore that more and start seeing a trainer. Or running, I don't want to run. I've never run in my life. I have no interest in it. I want to swim. Great. And we talk about that. But the mental side of things, worry, or more seriously anxiety, depression, have very serious effects on the joints.
For sure. But I guess I was being unfair because it was a leading question, because what I wanted to... Well, one of the things that I say is that, well, it's a normal finding for this age group. But if you're not symptomatic, we sort of just view it as white hair changes. Yes, it's imperfect, but we're sort of moving in that direction. So I think when we do an x-ray and then there's an incidental finding of a degenerative joint in your hip, but you're asymptomatic, do they need to come see a hip surgeon?
No,
or
I
do
don't
they
think
worry,
so.
or are they led by their symptoms?
So I guess the question would be, why did they have an x-ray?
I don't know, maybe a kidney, a KUB, I don't know.
Yeah, no, so somebody who has no symptoms doesn't need any treatment, I think.
Okay.
So I suppose we could talk about prevention. What do you do to prevent an arthritic joint from becoming a painful arthritic joint?
Right, so it's the pain that's the most important thing here.
So I have seen, definitely all of us have seen patients who say, I've suddenly got this pain, and they present and they have the most terrible arthritis.
I had
and
one
they've
yesterday.
just gradually stiffened up over time.
Yeah.
But that person is still living their life. So could they prevent themselves getting into that? Maybe. It becomes more of a philosophical question.
What I'm trying to get at is when do they need to see you?
Yes.
When they have x-ray changes and they're asymptomatic, when they can no longer carry out their activities of daily living, that's a marker we use. Where along that spectrum do you want to see them?
I want to see them if they are curious about their condition and they want more information from a hip surgeon.
Okay.
I would hate people to think they're coming to me to go under the knife. it becomes very disempowering to the patient. And so if they have no symptoms, I suppose a patient may say, I know I have arthritis, I'm scared, I want to know what my options are if I start getting pain. I think that's entirely legitimate. Why would we withhold information from the patient? Why would we say to the patient, you have to Google, or you have to insist your GP Googles? You know, it doesn't seem right or fair.
But what would you, for this recording, what would you share with those patients?
I would say you have arthritis in your you have arthritis in your hip. You don't have any symptoms. That's great. For patients who develop symptoms with this type of arthritis, hip replacement surgery is very well established. It is major surgery, but it can get rid of pain and stiffness. And
what are those symptoms? Because I think that's one thing we wanted to talk about.
Yes, so the hallmark of hip arthritis is groin pain.
Okay, what's groin pain?
Groin pain.
Yeah.
Pain in the groin area. Pain at the front of the hip.
Okay, so that crease line, you know, when you wear a swimsuit, that crease line, that's the area of the pain.
That's the area.
Okay.
Yes. Yeah, because patients often say my hip and they point to the side of the pelvis.
Yeah.
Yeah.
But it's actually within that crease
Within that crease. That is the most typical place to feel it. Having said that, I'd estimate about 10% of patients feel hip arthritis only in the knee.
Oh, wow. Okay, sorry. Yeah, explain this. This is interesting. This is a wow moment.
I thought you were getting bored, so I thought it. So, yes, they feel it only in the knee, and when I examine them, I can tell the knee's fine, the hip is very stiff. And
so you say, where are your symptoms? And they point to their knee.
Yeah. They come and they say, they come with a knee problem. And so it's quite good to have specialists. Our specialisms cluster, don't they? You have hip and knee specialists. You sometimes have a knee specialist or a hip specialist, but you often have a hip and knee specialist. You often have a spine specialist because the problems
biomechanically they're related. Yeah.
Yeah. And we can talk about how hip and spine interact. My GP colleague was very interested in that.
Okay.
So the ones who feel it only in the knee, they come saying, I've got a painful knee. I've got a problem with my knee. It's not going away. I've often tried taking some analgesics, painkillers. I've seen a physiotherapist. Still a problem. Actually, most physiotherapists will pick up that it's not the knee, it's the hip. But it depends a little bit on who they see. And they may be quite fixated that the problem is in the knee.
Oh, right.
And it's usually very clear from examining the patient.
Yeah.
And then I will usually take an X-ray of the hip and the knee. Yeah. And then show the patient, because it's very hard to convince them.
Yeah. Well, I explain it like heart attack pain. You know, everybody knows it goes down the left arm, but actually, do you know it's your heart? And it's a funny way in which our bodies are wired for nerve pain. Are there any other symptoms?
So sometimes just stiffness. Sometimes not pain as such,
Morning,
just stiffness.
Throughout the day?
Well, the patients who complain of stiffness and not pain tend to have advanced arthritis.
Oh, right.
So they have they've gradually stiffened and in some cases ankylosed over time.
Right.
And so...
so lost a range of motion.
Yes, and they say, I feel stiff, and it's all the time. It's hard for me to turn over in bed. You know? And they walk in with a really fixed foot position.
A fixed foot position?
Yes, because the rotation of where the foot lands depends on the movement of the hip.
Okay. And so that's evident as soon as they walk in? Okay.
And I'm really attuned I will always notice instantly if a colleague is limping or, we're just programmed that way, aren't we?
Yeah. Are there any words that sort of flag up when patients say, is it an ache, is it a sharp pain? What are the typical words that they use when they're describing their pain?
They say, it varies. So the spectrum of how much pain people are in varies hugely. I'm in agony. Unfortunately, I hear that.
Okay.
I'm in agony.
Yeah.
Really sad thing sometimes. My life is not worth living.
Oh, wow.
I need something to be sorted.
Okay.
And it's really hard. The really hard patients are the ones who have morbid obesity, body mass index over 40, who present with those symptoms, because I can't.
Yeah.
I shouldn't operate on them immediately. they need something different, and it takes time and it takes careful workup to define the metabolic situation and what's best for that patient.
So is there, what are your conservative options for them just to get them out of pain acutely?
So
to last for a couple of months.
Actually, getting in the water.
Okay.
Getting in the water is you're instantly.
So no tablets. You're not. Yeah. Okay.
Yeah. Let me start. Let me get started. But getting in the water is instantly you take gravity away, or you reduce the effect of gravity so much. A lot of patients get significant relief. Hydrotherapy, so getting in the water with a therapist, with a physiotherapist, is it can be amazing for patients who are in crisis. And steroid injection. Steroid is obviously very well established as a treatment. The controversy around it is there's strong evidence that a steroid injection increases the risk of periprosthetic infection if it's done within 3 months, maybe even 6 months of hip replacement.
Okay.
So that's tricky in patients who feel like they've put up with something for a long time and they want to have an enduring solution. But for patients who...
What's the increase in risk?
Well, the rate of infection, we always say it's less than 1%, but it depends a little bit on other factors.
Sure.
But it's minuscule.
Okay.
It's minuscule, but
so it doesn't even.
I think most surgeons would not with the strength of evidence. Most surgeons would not do a hip replacement within 3 months of that. But I certainly encounter patients who have had a steroid injection because they're seeing multiple providers.
Yeah.
And so
I've sent you a patient. She's had a steroid injection, but we had to do it. She had to know that she can't. She's exhausted conservative measures.
Yeah, sure. And patients who, I can't stand the idea of surgery. I saw a patient recently who was in his 80s who feels that he's too old to have surgery. I mean, he isn't, but that's his decision. He's having a steroid injection.
Tablets?
Tablets, yes. So
Which ones?
I find anti-inflammatories really helpful in a subgroup of patients.
Okay.
And I generally say, if you can take some sort of anti-inflammatory, ibuprofen or naproxen,
right,
take it for 3 days, and stop.
Okay, you're pretty. I think I'm more heavy-handed then. I give them a good 14-day course and then I stop.
Okay.
I tend to use etoricoxib because I think by the time they've come to me, they've probably had a non-steroidal anti-inflammatory with their GP, and well, obviously it didn't work because they're here to see me.
Was it etoricoxib? There was some controversy about the heart.
Correct. So I don't prescribe it with patients who have cardiovascular disease risk factors, but specifically if it's uncontrolled hypertension over 140. That's a definite no. But in the sports medicine world, I'm dealing with much younger patients. And for the knee, it works beautifully. And maybe I'll ask a rheumatologist in regards to joint specificity. But I was told the other day by a hand surgeon, you can try it, but those things don't really penetrate the small joints of the hands as much, so steroid injection is worth.
But why would they not?
Worth progressing. Well, this is the thing. But I know they work. I know they work beautifully. Because lower limbs, shoulders I'll try. But I wondered whether you had an opinion.
I think they're really helpful. For sure, I come across patients who say I took them for a month and I didn't feel any relief at all. So. I find it's very patient specific, but I think they have a role. And
I wonder by the time they've come to see you, they're more end stage than my patients.
Well, I see the whole in my NHS and my private practice. I see the whole spectrum of patients.
Okay, so can I push you on one thing then? So we live in a world, and it's for our listeners, but we live in a world where preventative strategies in healthcare is being touted as the new thing. So they want to be proactive. So if they've got... When's the right time to come see you? When's the right time to come see you? Yeah, that makes sense.
You know, I saw a patient yesterday, an NHS is absolutely bursting at the seams with capacity, but a GP had asked me to see a patient who had fallen and injured her knee, and he wasn't able to do an MRI scan. He thought that might be helpful, and I assessed her. She has got cartilage damage, patellofemoral cartilage damage. She's quite young.
Yeah.
I know that from examining her.
Yeah.
I haven't done an MRI scan.
Yeah.
And the reason I haven't done an MRI scan is that the patient doesn't want it.
Yeah.
Because patient expectations are so important that if a patient comes having heard from their GP, I can't do a scan for whatever reason, I'm going to send you to the specialist so you can have a scan, they are not going to feel better until they have a scan.
Right.
It's part of the therapeutic intervention.
Yeah.
And to ignore that or to dismiss it is ignores a fact. So did I need to see her? Who else is going to make her better? She's tried her GP. She hasn't thought to, whatever information is available publicly hasn't helped her.
So did you get the MRI scan?
No,
Or you didn't?
no.
You didn't think it was clinically
I didn't think it was
indicated.
clinically indicated.
She didn't want
want
it, but the
so we didn't do
GP
it.
had... Yeah.
So the GP had said, I think it might be helpful.
Right. Oh, but that's nice. Often I have the other, sort of another example where everyone's saying you need a scan. I'm like, you don't need a scan. But because their expectations have been set, I often end up getting a scan to treat them holistically, because they almost need some objective measure, and for them a clinical examination doesn't quite have that objectivity, even though I'd argue that that's possibly not the case.
I think it's quite helpful for explanation purposes as well. And occasionally I see patients with mechanical pain. They're having a mechanical effect, and there's something in the history or something about the patient that makes it clear why that should be.
So mechanical pain is like walking with a stone in your shoe and walking like 20 kilometres and then you get pain in your other knee because you're offloading. Is that what mechanical
Yes,
pain is?
I suppose so. Well,
So there's no pathology per se.
there's no pathology.
Yeah.
So I
But you're getting this
and
sort
I
of
can't
overload of one
always
joint.
tell. I can't
Yeah.
always tell if I'm going to see cracked cartilage or not.
Yeah.
But I might do a scan. The scan might actually look really, really good because the patient is listening to their body, listening to their painful symptoms. They don't know why they're getting pain. They need to change something about their. They need to change something about their physique, but the scan is quite helpful to show them where they are. This is the issue, and I say if you don't do something about it, this is what happens next.
So the sweet spot, you don't want to have a hip replacement. So I'm asking you. But I know that I already...
Do you need a hip replacement?
Yeah, exactly. So if I have my hip replacement when I'm 40...
Yeah.
Will it fail in 20 years' time and then I'll need a revision? Whereas if I can conservatively manage and engage with physio, maybe anti-inflammatories for the acute flares, and I can hold out until I'm, I don't know whether it's possible, 55, isn't that a better place to be? So is there a sweet spot, or is this so difficult? Is this such a... Is it a nuanced answer for every individual?
I think
explain?
nobody should have a preventative hip replacement.
Okay.
Because it's major surgery.
Okay.
And so if you're 40
Yeah.
and you are in pain day and night, you wake up with pain,
Yeah.
you can't walk down the stairs without pain, you can't sit at your desk for 10 minutes without pain, you take painkillers, nothing helps, nothing works, you have a steroid injection, it's still terrible, you have arthritis of the hip, then hip replacement may be the best option. And is that going to then lead to other problems? It could do. It could do. So
again, we're talking about the symptoms. Symptoms are key.
Symptoms are key. The figures that we have from analysing the National Joint Registry say that if you are under 50 when you have your first hip replacement, you have a 90% chance of needing another hip replacement in your lifetime. If you are over 70 when you have your first hip replacement, you have a 90% chance of not needing another hip replacement. But this, based on the National Joint Registry, the figures are historical. They're based on older techniques, older selection methods, older implants.
How long has this registry been going for?
Oh gosh, now you're putting me on the spot. A long time.
Okay. Decades.
A long time. Decades. But not since the beginning of hip replacement surgery, which started in the 1950s.
Okay.
So, that is, it's useful information, it's valid information, and you'll see written in many places that we expect to get 10 to 15 years of good function out of a joint replacement.
Mm-hmm.
And that's not really the case. We're seeing joint replacements lasting a lot longer than that. But there is definitely an activity and an age-related phenomenon, more for knees than for hips, very much more so for knees, but for every year of our life we become, on average, a little more inactive physically. So looking at activity levels of a 60-year-old, they are less active than a 61-year-old and a 62-year-old.
That's recordable. Yeah.
Yeah, and a 63-year-old. And so every year before the age of 65, where you have a knee replacement, you are more likely, you have a more likely effect of loosening the knee replacement prematurely. The same effect, we don't see the same effect in hips.
Okay.
And actually living with an arthritic hip is much more difficult for most people than living with an arthritic knee, because it's such a large central joint. So I would say if you are 40 and life is terrible because of your arthritic hip, there is no advantage to delaying treatment.
Okay.
It's a choice as to whether to live with misery or not.
Okay.
And yes, having hip replacement puts you into a category where terrible things are possible. There's a 90 to 95% chance of success with no problems whatsoever, ending in what we love to call the forgotten hip. So we have all these, suggestions. Don't put the hip into certain extreme yoga positions because it might dislocate. Actually, if you have good muscle strength and good restoration of anatomy, you can do what you like with your hip. You can forget about it. But I think most surgeons do.
That's the aspiration, to have a forgotten
hip. Yes, and it's pretty common actually.
Okay.
Yeah.
Okay. I'm aware that we could chat and chat and chat. So, is it possible to? I wonder whether we should do a second recording, because if I give you 5 more minutes, I just don't think you can answer the other 2 questions. But I mean, I think we've got a wealth of information there anyway for the first question.
I reckon I can do the GP in 5 minutes.
Okay.
Yeah.
Okay, that's a challenge. Go for it.
So, what do GPs ask me sometimes? I want to know who gets a hip replacement, who doesn't.
Yeah.
Because I don't want to refer unnecessarily.
Yes.
And my answer...
Oh, I feel like that as a specialist. So I just want to make sure that the GPs know that they're, they're not alone.
Yeah.
I mean, sorry, carry on.
Yeah.
You've only got 5 minutes.
And so are there age criteria? If someone is too old for a hip replacement, I don't want to refer them. I don't want to look stupid. I don't want to put the patient through that experience. What about someone who's 90? So in summary, there is no age restriction. That is ageism. And people are concerned about osteoporosis. Are you going to smash someone's bones doing a hip replacement because they've got osteoporosis? Osteoporosis is not really a disease. We treat it like a disease, but it's more of a age-related phenomenon that affects everyone. And all the treatments we have slow the rate of bone decline. They don't restore it. So care, attention, and particular techniques are useful in patients who are very, very old, 90 or above 90. But the oldest patient I've done a hip replacement on was 105.
Oh.
And the youngest patient I've done a hip replacement on was 19. So no, there's no age restriction.
Is it useful to get a DEXA before they send to you then, if they're worried about bone density? Does it help? With
I suppose in the holistic assessment of the patient, yes, but for the purposes of planning surgery, no.
No. Okay.
No.
Okay.
So who is going to be denied a hip replacement? Patients who don't have arthritis, I suppose. So I saw a patient recently, came with a diagnosis of knee arthritis. Doesn't have it. I think he's actually got a neurological condition. He's got spasticity in the legs. But he has an MRI scan where he was shaking. So the report is a little difficult to see what was going on, but I can't see any arthritis. And we've done x-rays which show, on no grading system does he have arthritis.
Yeah.
But he's got something wrong with him.
I think that's another key thing that I want to point out, because in my world, at least, patients, when they come, they present to me, Not with their personalities. Their personalities are unique, but with their presenting complaints, often it is textbook. So you can spot when something doesn't belong to your specialty because it just doesn't fit in one of those patterns. So you know that they need to go see a different specialist. So I guess that's true of this example that you've given.
Yes, exactly. So GP said to me, a patient, particularly an overweight patient, comes with groin pain. And they may get obsessed with, there's a hernia. The GP may feel that's the most likely thing. Being overweight is associated with hernias. So there's this fixation with, okay, how do I... And actually examining for a hernia in a patient who's overweight, I think is quite challenging. Mm-hmm. And then they end up having investigations, ultrasound scan. So what do they do about that scenario? Understanding that groin pain is the hallmark of hip arthritis. Most patients who have significant hip arthritis present with groin pain. Knee pain, yes. Also buttock pain sometimes. But that gets, then it's important to differentiate with sciatica, which can coexist. Mm-hmm. So what I would say to the GP about the patient with groin pain is an X-ray can be diagnostic.
Yeah.
But also the rapid examination. So
yes,
first,
I want to hear more about this.
Yes. So they've walked into the room. They've sat down. Don't be afraid to, there's so much value to saying, would you mind very much standing up and just walk across the room for me? Walk backwards and forwards. And you really want to look at a couple of specific things. One, foot position. On the painful side, are they turning the foot out? Mm-hmm. And some patients with advanced stiffness who only recently developed pain walk with obligate external rotation.
Okay, so like the foot is pointed to 2 o'clock position instead of maybe a 12. Okay.
Yeah. And you can say to them, can you turn your foot forwards? And with some arthritis, they'll be able to overcome that. Mm-hmm. They might tilt their pelvis as well.
They compensate, yeah.
With some, they can't.
Okay,
and that's
so they can't bring it back to the 12 o'clock.
That's a gold star in the diagnosis of hip arthritis.
Okay, love it. Give me more.
Next point. So you're also looking at the movement of the hip as they walk across the room, but that's more of a subtle thing. And Trendelenburg, if they have dysfunction of the lever arm, then the hip will sag on the other side as they walk across the room. But that's a relatively unusual thing with hip arthritis. The main thing is look at the foot position. Then put them on the couch, and my top tip here is whatever habitus the patient has, you can always find some part of the iliac crest. And I tend to put my index finger on the iliac crest, some part of it, and ask the patient, can you bend your knee? Mm-hmm. Because patients will understand that more easily. Particularly with a big patient, if you're trying to lift the leg up, it's quite challenging. So it's just quick and easy, one finger on the pelvis, can you bend your knee? And with a very stiff hip, you'll feel the pelvis rotate.
Oh, love that one too!
And the earlier sign...
So in a normal patient, pelvis is neutral.
Pelvis
bend
neutral,
the knee,
pelvis will stay
remain.
still.
Okay,
pelvis
get
will
it.
stay still. You'll be able to bend the knee and the hip all the way up and all the way down.
Great.
It'll be fine.
Thank you.
Yeah. And then patients who have subtle arthritis, you'll be able to bend the hip all the way up, but you'll have that loss of internal rotation and flexion. So as you, and it's quite, I'm quite small, as you know, but our listeners may not be able to see that. But the trick is to stabilize the side of the thigh, and I lay my forearm across the patient's lower leg, and then you use the lower leg as a lever to just gently, without hurting the patient, watching the patient's face, bring the foot out towards me, rotating the hip internally. Yeah. And they have stiffness there. That's a relatively earlier sign of arthritis.
So it's a loss, and you compare one side to the other.
And I would suggest that takes the whole of that could take you 90 seconds.
Okay.
And then you can do an X-ray. You can do an X-ray.
But not needed?
Not needed, no.
Why not needed?
I'm very
because
happy
you can
to
just
see
refer.
X-ray, but yeah, so...
You can refer straight to the hip surgeon without an X-ray.
Yeah, so it's quite some time ago, the British Hip Society and the Royal College of GPs collaboratively wrote a document which basically said, if you take an X-ray, it will tend to underestimate the prevalence of hip arthritis.
Okay.
You will see very subtle changes sometimes, or a normal looking X-ray sometimes, an X-ray that comes with a normal report, and the patient has significant arthritis. But you'll know if you examine them.
Okay. So that's another reminder, a useful reminder for patients as well. That clinical examination, in our eyes, is an objective measure. Okay. And so good to know that that's probably all you need to then refer to a hip surgeon, and they won't mind.
Yes.
Okay. Any bloods or anything that they need? Any?
I have seen a patient who came saying, my mum had a hip replacement when she was 45, and I'm worried. And the GP referred the patient. And that's okay,
Okay, you were laughing. I was worried.
No,
it's
but
okay.
I feel like I'm on this earth to do what I can to do good for patients.
Yeah.
And the best way I can spend my time is in operating, because there are a few people who can do that.
Yeah.
But actually, the conversation about what I know and what the patient needs to know is of value.
No, for sure. I think the difficulty, at least within the NHS, is that the GPs are pressurised, and they cannot refer everybody just for a friendly conversation with the specialist. That's the idea of this.
So the one thing I wish they would think about is to measure the body mass index.
Okay, so not bloods, but BMI.
Yeah.
Okay, great.
I don't need any blood tests. The body mass index is so key, because if a patient has a body mass index over 40 and the first time they know is from me, emotionally that's quite a big thing for them.
Okay, so maybe have that preparatory conversation.
It helps them with their journey.
Okay, cool.
And they may even end up seeing a bariatric specialist before me.
Yeah. Thank you. Is that all you want to share with GPs? You want to share everything more. I have to go to work now. So I think we should leave it for the third question, because I want to know more about sexual discrimination, or how would you phrase
Sex misconduct.
Misconduct.
It's a behaviour.
Sorry, that was my brain just.
No, it's. I think it's very natural you describe it like that, because.
No, but discrimination is completely different, right? In terms of
they are overlapping themes.
Okay.
And sexual misconduct is, in healthcare in the UK, we didn't have a term for it 7 or 8 years ago. These incidents would happen. People would scratch their heads. Yeah, no, of course. Like, what would you? I remember very clearly discussing this with a colleague, and I wasn't a consultant. I was a fellow, and I was speaking to a consultant and describing an incident. And he's like, "Oh, this." On the one hand, we know that people are behaving like this, but on the other hand, what can we do about it? And is there a name for it? We didn't really understand a lot that we do understand now.
Yeah.
And sexual misconduct is a very powerful undermining of any efforts towards including particularly women in the workplace.
Okay. So I would like to ask you more about that for our final question. But you may have something else that you want to talk about. So let's think about it. Let's see whether we should have a part 2 where we talk about the sexual misconduct, because it's such an important subject. And you are the expert, and I want to hear more about it. And I think this is a good enough platform to disseminate that kind of information.
Yeah.
But I also...
I know you like figures.
Yeah.
So if I just give you some figures,
parting figure.
I'm part of a group, a working party against sexual misconduct in surgery, set up in collaboration with the Royal College of Surgeons about 18 months ago, and almost a year ago we released our survey of the UK surgical workforce, and of the people, we had 1,400 respondents who completed the questionnaire, and of the women who replied, around 30% said they had been sexually assaulted by a colleague.
You sent me the Guardian article, and I 30% for me is almost inconceivable. It's a huge number.
But also we must put that in the context of the definition, which is unwanted sexual behaviour with physical contact. And not so much now. There's been a huge change over quite a short space of time in the last 3 or 4 years.
For the good or for the worse?
For the good.
For the good.
I mean, it's people are talking about it, so it may seem like terrible things are happening that never happened before, but of course that's not true. And even 5 years ago, I can remember a colleague saying, I did a bit of bottom slapping, so what? That's sexual assault.
I want to talk about a specific case that still haunts me to this day. When I was an F2, I witnessed something, and I think I was so shocked I couldn't speak up. So I do want to share that with you, because I want to, and I think the important thing is that it's all about progression, and now that we have the language to be able to describe these instances to each other, that's the first step.
Yes, and I think in this, kindness is very important, kindness to ourselves, because people sometimes are, particularly in medicine, very self-critical, struggle with compassion towards themselves when we make mistakes. And to learn and to move forwards and to progress, we need to a certain extent, move away from that feeling of horror and say, okay, how do we learn from this? How do we protect others in the future? That's what it's all about.
For sure. Thank you, Homa, so much for coming.
It's my pleasure.
So much time explaining these.
I always have a great time with you, Brynda. And
no, you're being too kind.
And I always learn something.
I think you have a great time with most people, but thank you.